Thank you all for joining us today for the National Bone Health Alliance Fracture Prevention Central webinar series, Foundational Tools for Setting Up a Fracture Liaison Service. For those of you who don't know me, I'm Debbie Zaldo, and I'm Senior Director of Clinical Programs for the National Bone Health Alliance. NBHA was launched in 2010 as a public-private partnership that brings together the expertise, resources of its public, private, and nonprofit sector partners, using its collective voice and diverse membership base to weigh in on subjects important to bone health, particularly vitamin D, calcium, bone density testing, reimbursement and utilization, benefits, risks of the use of bone health therapies, ongoing communication, shared priorities and projects to become reality through pooled funding, and working together toward the goals and recommendations of the National Action Plan. NBHA has 55 organizational participants, which include 51 members and 4 government liaisons, all working towards NBHA's 2020 vision to reduce bone breaks 20% by the year 2020. One of our major resources to help us achieve this goal is Fracture Prevention Central, which is a website, which I'm sure you're all familiar with, where we have key resources including brochures, materials, that you can download and use for your programs, as well as our Fracture Prevention Central webinars, which are all available on demand, as well as on our YouTube channel. I just want to bring your attention to some upcoming Fracture Prevention Central webinars. One that is June 20th on the NBHA NOF Quality Improvement Registry. And as you'll see, we have others planned all the way through October of this year. You can go on Fracture Prevention Central to learn more about each of these webinars as well as register. The other program I wanted to mention is the NBHA One-on-One Consult service, which is available at no cost. That is also available on Fracture Prevention Central, where you can fill out some forms so that we can identify the questions you have and then connect you for a free consult with one of our experts on the specific issue you're looking to address. Now it's my pleasure to introduce our speaker today, Ann Lake.
All right. Hello, everyone. I hope you can hear me well. And I'm so glad that you're joining me for lunch. I'm actually having a little sandwich myself while we're doing our webinar. So it's great to have you all on. I've kind of reviewed some of the attendees, and I know we have some people from industry and we have some people from different healthcare systems. So it's a pretty wide variety. But I do want to go ahead and make a point that each of us probably comes with a different level of experience or a level of understanding of what the actual FLS program is. And so I'm going to run through the basics just at the beginning. But I really thought we might get into some of the nuts and bolts today of a truly successful and sustainable FLS program. What I'd like to see you all do is, if you already have pre-listed questions, or maybe some things that you were particularly trying to highlight today or wanted to get from this webinar, I'd like for you to go ahead and maybe start sending those questions in, so that if we need to address questions, I'd rather address your questions than spend a lot of time on a slide presentation that may not, give you as much benefit. So send those questions in. Go ahead and get those started as I get rolling. Debbie did a great job of introducing me. I appreciate that, Miss Debbie. And actually, I'm trying to figure out how to advance my slide. Now, where do I do that, Debbie, on this big screen? Debbie? Debbie, are you there? Okay.
And you can just use your arrows, and that should move. You may need to click the slide, and then just as you would usually move through a PowerPoint, it'll go.
Where is the arrow, though? That's what I don't see on here.
Whoops. Great. Can you find it to move forward on your slides, just as usually as you would move forward PowerPoints on your computer, like you were clicking through earlier?
Okay, there we go.
Okay,
I got
awesome.
it. Thank you so much. Appreciate it. All right, sorry about that, everyone. All right, so we're going to kind of talk about the roles and the daily activities of an FLS program. And again, I want you to send your questions in. If we have a few opportunities to go through a couple of case studies, we'll like to do that as well. But just as a general reminder, remember when you're thinking about the FLS program, there's a lot of different presentations that have been out there related to bone health programs and osteoporosis programs, but particularly for this webinar, we're really focusing in on the concept of a fracture liaison service that was adopted from the Capture the Fracture program that was started in Europe over 15 to 16 years ago. If you are not familiar with the Capture the Fracture program, I would love for you to read that article. You can actually Google it, or that actual resource is available through the Fracture Prevention Central. But if you truly want to understand what its pure FLS service is all about, that's the best resource for you to understand where we got the idea in the United States for the FLS, that it came from Capture the Fracture, and it was actually based on identifying the patient that had a fragility fracture that presented to the orthopedist, and the orthopedist was the open door provider that actually identified the patient, captured the patient, and appropriately either did the investigation themselves or actually sent the patient to a specialist to get that investigation done, and then the patient was initiated on therapy. So I don't want us to get caught up in the concept of this is primary prevention, bone health, metabolic bone disease. We're really talking about the structure of a pure FLS program. So when a patient presents with a fragility fracture, they can actually have a fairly decent bone mineral density test in the past. They may have very little bone loss, but if they have a fragility fracture, we get concerned about the bone quality, which that can affect the bone strength. So keep in mind that it's really the bone density, but it's really truly the bone quality at that point that equals the bone strength. So you have to look at not only the mechanism of the way the person fractured, but also their medical conditions, their medications, and those kind of things that can also affect their overall bone strength. All right. This is just a quick position statement from the American Academy of Orthopedics stating that they need to make it their priority to do a better job of capturing the patients. We know that fragility fractures are an epidemic, especially in the United States, with an expectation of 44 million people with having osteoporosis going forward, and the cost related to that. So this is a basic picture of what an FLS program flow model may look like. It may look a little different in your institution if you have one going, but if you're just getting one set up, this is kind of the basic format of how the patient would follow through the system. So you have this new fracture that presents. The patient can come to the emergency department. They're going to get those x-rays, and an orthopedic trauma surgeon or an orthopedic provider who's on call is going to be consulted. If the patient has a fracture that needs to be treated surgically, or the patient needs to be inpatient admitted, then the orthopedic trauma surgeon or the orthopedist will talk to the hospitalist, and they'll have this team approach to the patient. Patient's admitted, and the patient can be identified on the acute care side. If the patient comes to the emergency department and they're actually treated in the ER and then discharged, that would be considered, the outpatient flow process of this. And so the patient needs to be identified either in the acute care setting or at some point in the emergency room. And you've got to think about how is that patient going to get to your FLS clinic. So they're coming in two ways, through acute care, emergency department, and discharge. And then how are they going to get to your FLS service? Because the identification and the capture is the biggest challenge when it comes to setting up a successful and sustainable program. So that's where that integrated team approach has to take place. If you're conceptually thinking, well, how do I communicate with these people? You want to think about key people on the continuum line of care where this patient is going to come in. Maybe you talk to the ER triage nurse and say, we want to set up this program, these are the patients we want to capture. Maybe you find out how the patient gets an appointment with an orthopedist when they're discharged from the emergency room. Maybe you want to find out from the case manager how the patient gets the appointment after discharge from acute care. I mean, you've got to think about the strategic people that are along this continuum that can help you get the patient to your fracture liaison service. So again, this is a very busy model. It's got a lot of great colors. I love it, but it is busy, so I'm going to run through it real quick. Again, the patient's admitted to the hospital for surgery after fragility fracture. The FLS coordinator or the nurse navigator in the hospital can identify the patient. The patient may be treated for fracture in the hospital and then has that 3-day window or however long they're in the hospital. That gives you a little more time to identify the patient. If they're discharged from the ER, that's the little glitch. You got to figure out how they're going to get to you. You may want to get a list of those patients that were seen in the ER. The patient may then be discharged to home or to a rehab facility. So you can see where the patient can go in different directions, and that's why it's important to capture them at the onset from the orthopedic department when they've had that fragility fracture. If they're not seen by orthopedists and they're only seen by maybe an internist in the ER or an emergency care physician in the ER, and then given that referral, you want to find out where's the piece of the puzzle that will get that patient to you. How does the communication line go from the ER to the FLS provider, and where does the orthopedist fit into that? So you all can read this and digest it and everything, but this really is the main part of a successful FLS program is that capture and identification. So if you notice, I've focused in on the first dive, which is obviously the identification of the patient. So let's talk about that challenge that comes when the patient's admitted to the acute care. So one of the challenges is how to identify the patient. Who's responsible for the communication pathway? Is it the ER doctor, the medical doctor who's taking care of the patient? Is it the nurse? Is it the secretary or the orthopedic surgeon? If there's a designated FLS coordinator or a nurse navigator in the hospital, that they can help track this patient, but you've got to think about, okay, we can identify him, but how are we going to communicate with the patient? So one of the obviously recommended solutions here would be that you recommend a team approach, identifying the key people in that chain of care and put your team together. Where the patient comes in, who's going to see the patient first, who's touching the patient, because really at the end of the day, it's everyone's responsibility to identify that this patient has a need for further evaluation treatment for their bone health. So again, I always use this example. If you've heard me speak before, I use this example that if a patient comes in and they've got a medical problem and all of a sudden you find out they're diabetic in the hospital or in the emergency room, but you're treating that other medical problem, you're also going to be looking at that diabetes, because you know if they don't get the diabetes under control, it's going to affect their outcomes. And so regardless of whatever they presented with, you now need to focus on that secondary problem, which is that diabetes. So the same thing goes with a fragility fracture patient. Any patient greater than the age of 49 that's had a fracture, a fragility fracture, you want that patient to be seen and have a bone health evaluation, because you want to improve their overall outcomes and improve the value of care that can be provided for that patient. So another challenge is patient makes it to the floor. Then what happens? Well, once the patient's identified, who's responsible for documenting the further need for investigation? What will be completed in the hospital, and what will be planned for outpatient follow-up? What labs do we do? What do we do a bone density? So one of the solutions that I mentioned here is if you have an FLS coordinator, maybe your system has a nurse navigator in the hospital who's not an advanced practice provider, but who can identify the patient. Maybe you have a nurse practitioner or a PA or a non-surgical provider on the outside of the hospital who's going to be your fracture liaison provider. But either way, you've got to have that communication. So the FLS coordinator maybe an advanced practice provider or a physician with an NPI number that can start the appropriate workup. If they're doing it in the hospital, right now it currently is a billable visit, and I think a lot of advanced practice providers may be initially seeing the patient in the hospital for that billable visit. Here at Wake Forest, we got so busy and really just did not have time to see every patient. So we also found that it was more cost effective for us to do the workups on the outpatient side now. So basically we simply identify the patient, inpatient, and then we get a list and we make sure they have a follow-up appointment with me on the outpatient side. If there's not a provider that's going to do an inpatient visit, the investigation can certainly begin with appropriate documentation in the hospital that just says that the patient had a pathological osteoporotic fracture or a fragility fracture, and they're going to be appropriately referred to the fracture liaison provider as in the outpatient setting. As far as labs and bone density, the main issue with labs is you absolutely need to have something married to whatever you order. So in other words, there has to be a marriage between your order and the labs, or what you're ordering and the diagnosis. If you don't have a supporting diagnosis, you better not order that lab because it's not going to get covered, and your hospital is going to come back and say, this is costing us a lot. So the main things that you want to try to get in the hospital would be, you know, your vitamin D at 25 if you can get that done. A lot of times if a patient's been admitted, you're already going to have the metabolic panel done, maybe some other lab tests as well, a blood count, and those kind of things. The bone density cannot be done in the hospital because it's not covered in the hospital, but if the patient is in your network of system and you can find a bone density that was done in the last few years, that's great. It's great news. It's in there. But if not, that workup can be done on the outpatient side. So most of the workup can certainly be done outpatient. Again, the patient has to be identified though. That's the key point. So another challenge is, what does the documentation look like? How will the patient be informed and educated about the FLS service and why it's important as part of their care? So the solution here, documentation in the acute care setting, it needs to include any supporting medical history, medications that the patient may be on, fracture history that would indicate the patient's need for further bone health workup, for secondary fracture prevention. That all justifies the visit. Now, if you're doing a visit in the hospital, your hospital visit is going to look completely different than your outpatient face-to-face visit, because your hospital visit is really going to be more about your data, gathering the data, mainly getting the HPI on the patient. You've got to find out how engaged your patient is about the education in the hospital setting, if they're on a bunch of pain medications, or they're getting physical therapy, and maybe they're not ready to receive the education. So you kind of have to look at your patient population and see what works best there. But most of your acute care documentation is simply going to be related to what was just mentioned. Now, the outpatient documentation is certainly going to look a little bit different, and we'll get to that. So the things to consider, be cautious about the labs that you order when the patient's in the acute care, because many labs are not recognized as medically necessary and will not be covered. So you want to check with your coverage area, your billing people, and you want to find out what's covered in your area. Again, back to my statement that make sure your orders are married to the diagnosis for proper reimbursement. And I've given some examples over here for things that would be covered if you're looking for particular labs, if you're doing in the acute care setting. In the outpatient setting, you still will run into some of that. But by the time they get to outpatient setting, again, some of these other labs may have already been taken care of for you. Remember that as far as documentation, it's mainly going to be a reflection of your time, summarizing the medical record and performing the patient's interview. You need to be realistic, again, consider the patient's ability to engage in that acute care visit. And explaining to them, what they can expect on the outpatient visit. Close to discharge, again, the patient may feel overwhelmed with everything about their experience and their retention ability. I would definitely have some simple education tools. We have a video that we created that's certainly available to folks if they're interested, but it's just a 2-minute video in English and Spanish, and it explains the FLS service. You could also, I think I've heard other providers using like little postcards that just introduce the FLS system, and they really should all reflect to the patient and the family the goals of the program, and that is for them to have a break-free future, no future fractures related to their osteoporosis. As far as understanding, understanding your patient population is the most important thing, whether it's a large medical institution or whether it's a small institution. The main thing is making sure that the goals of the patient match the goals of your institution. And the goal of the patient obviously is to recover and to not fracture. Well, the goal of your institution is to improve the value of care and to reduce readmissions. And so all of these things fit for that FLS service. So I'm going to take one moment here and look to see if we have any questions in the queue. And let's see, somebody has a question. Great. Hang on, I'm scrolling through. Any suggestions on how to approach a hospital system from private practice standpoint to establish an FLS program? Previous talks make good points on financial benefits, etc. Okay, I'll address that in just a moment. And Debbie, they want to know if they're going to get a copy of the slides, and I think they certainly are welcome to have those. All right, so I'll answer a few more questions as we go. Let's see. Go back to my slides over here. All right. I'm going through the slides, people, real quick, just because I want to make sure that we highlight what we need on this particular call. All right. These are all my case studies. Okay. All right. All right. So those are the main slides that I wanted to cover in the introduction. Excuse me while I scroll back real quick. And so let me see if I can answer that first question for the provider who was asking related to how do we approach a hospital system. Okay, so when you think about what's coming forward with our reimbursement system, we are now moving away from fee-for-service model more into a value-based care model of reimbursement. You may have heard of programs like the Metrics Incentive Payment System. You may have heard of things like alternative payment systems, or some of you may be in the regions where they're doing comprehensive joint replacement bundled payments. You've probably heard of that lingo. So the way that you can approach a hospital system from a private practice setting is you basically bring them a gift basket, if you will, and not literally speaking, but you basically can bring this to them and tell them that you are interested in setting up an evidence-based, which is all what we're having to be treating patients on, evidence-based quality care program proven to reduce the risk of readmissions and future fractures, and it's called a Fracture Liaison Service. You can also, there is a slide available that you can have, and it actually shows that there are more hospitalization costs related to osteoporotic fractures than there are admissions related to heart disease, stroke, and heart attacks. Breast cancer. So more osteoporotic fracture admissions rather than heart disease, breast cancer, and stroke. The cost of those hospitalizations are greater, and yet we still have this huge gap in care. And so your presentation is really just to meet their need. You basically would educate them on the fact that you can present this program to them saying, I can help you meet your goals, meet your quality care measures, because if you're treating patients with fragility fractures or hip fractures or any kind of fractures, this is going to be part of what you're going to be reimbursed on going forward. And if I can help improve the value of care for you by our services being brought to your clinic, we just want to work with you on a care coordination model to be able to meet the needs of your patients. The other thing is you can use the language of improving the value of care that every patient served within that institution is getting. And I think that is probably one of the greatest things you can do in terms of justification, to do that for them. The financial benefits will be that it will help improve their contracting with their insurance companies going forward, because when they're beginning to be paid on bundle payments, if you think about it, if they have a patient that had a hip fracture and they had to have a hip replacement after that hip fracture, they only get one payment. And if the patient has any complications within that 90-day period, any complications, get readmitted or have a periprosthetic fracture or get an infection, they will not get any more money during that 90-day period of time. So what you're providing them is a way to help reduce the risk of complications post-fracture, reduce the risk of hospital readmissions, and therefore it's improving their costs and decreasing their risk of penalties going forward. But that's kind of the language, and they have that information. You just have to put it in the language that they understand. So the words that you want to kind of use would be evidence-based, care-coordinated model, quality care program proven to reduce the risk of readmissions related to fragility fractures, proven to reduce the risk of fragility fractures going forward, and complications related to osteoporosis. So that's the language that I would certainly recommend that you use. And going forward to try to sell it to your hospital. So I have another great question here. Having a lot of patients not keeping their appointments to the FLS. How can we increase the number of patients keeping their appointments? Well, that's a great question. Again, that's how you know if you have a successful and a sustainable program or just a successful program. A successful program means that it's been marketed and it's out there and it's wonderful and everybody knows about it, but nobody uses it. A sustainable program is a successful program that's been marketed, and every person along the continuum of care within that health system knows that that program exists, and they know how to identify and get the patient referred. And then when the patient gets in front of the orthopedic provider says to the patient, part of the value of care that we want to give you is to reduce your risk of a fracture. We're going to make sure that you get at least these several things to help improve your care. Number one, we're going to make sure you get physical therapy. Number two, we're going to treat your pain and keep you safe. Number three, we're going to make sure that you don't have any infection or complications related to it. We don't want you to have any blood clots, so we're going to treat all those things. Number four, we don't want you to fracture again, so part of your care will include a bone health evaluation, and it is mandatory and strongly suggested that you keep this appointment. Just like it's important for you to keep physical therapy appointment, it's very important for you to keep this appointment as well. A lot of the reason patients don't show up is because, number one, they have not been told why they need to go. They've not had a really good communication pathway that has encouraged them and educated them on the reason that they need to go is so they don't fracture again, okay? And that treatment is very important. So again, it goes back to whatever your communication line is with your patients, whatever your system currently has set up. That's why I think if you can capture the patient on the inpatient side or in the ER with a little video presentation of why they need to go and a little card, make sure they already have the appointment made. And then if they don't show up, the FLS coordinator or provider, this is what I do. If a patient does not show up for their visit with me, I immediately send a note to their orthopedic surgeon. And I say to their orthopedic surgeon, to let you know, thank you for this referral, but the patient did not show up. They have a follow-up with you in such and such a time. Will you please reiterate the importance of coming? I can tell you, hands down, participants, that every time I get the orthopedic surgeon to tell the patient they need to go, the patient comes. Because the orthopedic surgeon looks at them and says, I fixed your fracture, I don't want to be fixing another one. I don't want to fix another fracture around what I just fixed. You really need to go to this evaluation. And it's amazing because patients, they really get it at that point and they really listen to the orthopedic surgeon. That's why it's so important that you have orthopedic buy-in. you've got to have the orthopedist on board. Whether your FLS is driven through the orthopedic service like mine here at Wake, or whether your FLS service is driven through another pathway, whether it's orthopedics and then endocrinology or rheumatology or gerontology or pain management or interventional radiology. There's many, many pathways that can take place, but you absolutely need to have the orthopedic buy-in. So be creative and think about how to get those patients to you and how to keep them compliant. The other big issue is, I mean, I hate to say it, but I have had patients that have had another fracture in 6 to 12 months, and they come in and they look at me and they shake their head and they say to me, I wish I wouldn't have refused my first visit because now I'm back again. And people are getting it. They're getting more educated now, and I can promise you, if you use the word, we want to improve the value of care that you're getting and we want to keep you safe, patients, they will most of the time kind of be engaged in that, and a lot of times they will keep that appointment. I think the other challenge that oftentimes we run into is that it's hard sometimes to get the patient in for multiple appointments. So if you do have the luxury at all, if you do have the luxury of being able to make your orthopedic follow-up appointment on the same day as the FLS appointment, that really is much more beneficial, and that works a lot for my skilled patients. If you can coordinate a same-day visit, and it is billable. Even if they're seeing the orthopedic provider for their post-fracture care, they're still in the global period, but they can see the FLS provider on the same day, and you know, and get that visit in. And sometimes that will save the family an extra trip in when they have to come in with a skilled patient, or if you have a patient that has some memory loss or memory issues and has to have a caregiver come. Sometimes that care coordination piece can help. And that's where I would go back to whoever's scheduling those follow-up visits with the orthopedist, maybe tag on that FLS visit if at all possible, if your system will allow it. Now I know it's unrealistic in some situations, but that is another idea for you. So if you guys are good, I'm just going to keep answering your questions because after looking at the people that are participating, I feel like most of you are pretty well versed on some of the patients or how to set up an FLS. So I'm going to continue with these questions. How do you handle when the hospital says it is a clinic thing and the clinic says it's a hospital that will benefit? Well, okay, so here's how you handle it. They're right. It is a clinic thing. It needs the workup needs to be done primarily on the outpatient side, okay? But I believe that I just sort of mentioned that the hospital benefits because going forward, right now the hospitals have been sort of, you know, well, we're still fee for service, we're not going to worry about it. Well, I guarantee you, in 2018, there's 50% of our payment model will be on alternative payments. On an alternative payment model. So 50% of our reimbursement is going to be on an alternative payment model, which means it's primarily going to be bundled payments and those kind of payment systems within our hospital system. So how the hospital is going to benefit is if they can make sure that they maximize the quality of care that the patient is receiving after that fragility fracture to help reduce their risk of another fracture and complications after they've had a procedure for that fracture, they are less likely to have another readmission, which is going to cost them money. They're less likely, the patient is less likely to have a complication, which is going to cost them money. The patient will report an improved value of care, which if the patient does not report that they felt they got good value, the hospital will be penalized for that. So the hospital is going to benefit because they're giving the patient improved value, so they will benefit by improved contracting and better reimbursement and less penalties. The clinic benefits because the clinic actually is still going to be on a fee-for-service somewhat type of model, but it's a hospital system as a whole that actually benefits from the whole outcome. As far as clinic providers, we benefit because we can also bill, or actually not bill, we can actually report on the measures that we're using that help improve our outpatient reimbursement service line. So we all are going to benefit, but it comes from two different pots. And that's why I think hospital organizations tend to sort of say, well, this is acute care, this doesn't really affect us. Well, yes, it will. And then clinics tend to say, well, this is outpatient, this is not going to affect us. Well, yes, it will. But you've got to think about it, it's coming from two buckets of resource, of reimbursement. But at the end of the day, everybody is going to either benefit or suffer from penalties or from maximizing value of care by improving the value. The person who asked this question, I guess I would throw it out there. One of the things that I would say to that organization that's telling you it's not a hospital thing, it's a clinic and vice versa, I would say, is that what you would say to your diabetic patients? So if a patient comes into our hospital and they have diabetes, we're not going to talk to them about their diabetes while they're in the hospital. We're not going to do anything about it while they're in the hospital, right? Okay, well, that's ridiculous, right? A patient comes in with a heart attack and they've got high cholesterol. We're going to treat their heart attack, but we're not going to talk about their cholesterol. No, we're looking at the whole person. So I would represent to them and say, no, this is a value-based care model that's going to help reduce the risk of fragility fractures, and that's a sentinel event that causes more readmissions than heart disease, breast cancer, and stroke. Okay, but we have all kind of quality care programs in hospital settings, okay, that work with outpatient clinics to make sure patients get diabetic education, breast cancer screening, cardiac rehab, CVA, stroke prevention. We need osteoporosis, bone health prevention models, and secondary fracture prevention models. So that's a great question, and you could tell I got on my soapbox a little bit. Okay, so another question I have is, how could I institute a model for younger patients who may be at risk or have osteoporosis? That is a great question. So the two things that I want to address real quickly are that in the SLS service line, again, the main focus has been on secondary fracture prevention. So it's been on that patient that does have osteoporosis by definition because of their fragility fracture, and so we're really looking at identifying the patient with osteoporosis at that point. And that is considered secondary fracture prevention or secondary sort of osteoporosis treatment and management. If you're interested in setting up a primary prevention model, which would be the patient that what you mentioned is at high risk, or maybe the younger patient who may or may not have been diagnosed with osteoporosis, then you're really kind of talking about more of a primary prevention approach for bone health. And so that your language may look a little bit different there. Your statistics are still pretty much the same as far as patients that we know that 1 in 2 females over the age of 50 are going to have an osteoporotic fracture in their lifetime, and 1 in 4 males over the age of 50 will have an osteoporotic fracture in their lifetime. And so from a primary prevention standpoint, it would be important to know, postmenopausal women have a high rate of bone loss in the first 5 years after menopause. You would want to know what your treatment protocol should be for that primary prevention patient. You also may want to look at some of the clinician's guide to treatment and management of osteoporosis that's actually available through the National Osteoporosis Foundation. You can download that, and it kind of gives you some guidelines on primary prevention of osteoporosis. So hopefully that answers your question a little bit, but particularly that question really focuses in on primary prevention, which is absolutely important, but that's not really where our gap in care has been. Our gap in care has not really been related to primary care providers or gynecologists or other providers actually doing bone density tests and talking to patients about calcium and vitamin D and exercise. That's not really where we've had a gap. Our gap in care really has been in those patients that have had fragility fractures, because the research currently shows that only about 22% of the patients that have had a fragility fracture actually are identified and an investigation done and are actually recommended some treatment, and only about 70–80% of those patients are actually missed. So the FLS is really to capture that 78% that we're missing and to try to do a better job. And as a whole, if we can do that, I think we're going to have a lot more screening done, a lot more primary prevention, and then we're going to meet osteoporosis as a disease head on, not only from primary but also secondary prevention. So Debbie, how are we doing on time?
Yeah, we're still good on time, so we have some time for more questions from folks. For everyone, you can enter your questions in the question pane, and we'll be able to see what you've entered in and hopefully be able to answer your question for you.
Perfect. So I think I have gone through a lot of these questions here. Were you able to address, will they be able to get this copy of the slides?
Yes.
Okay, good.
Of the slides as well as the webinar itself will be posted to our YouTube channel, but everyone who's attending the webinar will receive the slides as well as a link to the YouTube webinar in an email next week.
Perfect, perfect. So let's do this. I don't have any questions in the queue right now. So what we can do right now is let me kind of, I don't think this will play. Let me see. No, it won't. Okay. So I was going to try to see if I could play my video, but that was a last minute thing. So don't stress, Debbie. That was just a last minute thing. All right. So let me go ahead. Let's talk about a case study real quick. Let me just tell you like a classical patient that you might see in an FLS program. So there's a 71-year-old male, hip fracture, low trauma fall, past medical history of kidney stones, coronary artery disease, hypertension, congestive heart failure, small bowel resection, which I highlighted for a reason. Current medications, he's on atorvastatin, metoprolol, he's on some blood pressure medicine. He hasn't really been compliant. I do want to point out to you that that is actually a new code you can use in your FLS service. If you need to follow up with a patient sooner than later, you can actually use a code that says non-compliance or adherence with medication. So that'll justify another follow-up visit if needed. So this is a male patient with a hip fracture with multiple comorbidities. There's a look at his x-ray. There you go. His risk factors for fragility fracture and bone loss. He's had previous small bowel resection, which might decrease ability to absorb vitamin D. He's had an increased risk for falls, if nothing else, simply for age. But guess what? He just had a fall, so he's at risk for falls. He's on a walker after his hip fracture. There's no history of parental hip fracture or osteoporosis that he's aware of. No history of oral steroid use longer than 3 months, 5 to 10 milligrams in his lifetime. He doesn't have any excessive alcohol or caffeine intake. Here's a look at his bone density. The femoral neck score is -2.7. I'm going to point out to you all, and I'm going to ask you a question. Do I need a bone density to tell me that he has osteoporosis since he's had a hip fracture? And the answer is no. But we have a bone density anyway. And it confirms he's osteoporotic. His T-score in his femoral neck is -2.7. He's had a compression fracture in his spine. You can see the worst level is at T8, but you got to at least use 2 vertebrae. The IFCD guidelines are don't ever look at a bone density and only look at 1 vertebrae. You should at least look at 2 vertebrae when you're looking at bone density test. That's his LVA. I apologize. That's his LVA, and it does show that he's had a compression fracture. But when you're looking at bone densities for the lumbar spine, make sure you're looking at 2, at least 2. So because this patient had never been on any treatment, we can certainly do a FRAX. However, in the presence of osteoporosis, a FRAX score is not really indicated, but this tells you what his fracture risk is. 19% being high end. Hip fracture is 7.7%. So the bottom line is he's got a high risk of another hip fracture because he's had this other one. The lab results showed that he was deficient of vitamin D. This particular provider actually did a bone marker on this patient, did an SPEP on the patient, a serum protein electrophoresis. When you do an SPEP, you're looking for things like multiple myeloma. This patient also had a celiac screen, a thyroid test, and other tests done. I'm going to be honest, I'm not the provider for this patient. I probably wouldn't have done a testosterone on this patient because I'm not going to put him on androgel therapy, but it's something to consider. Obviously, if you want to draw, that's great, but it's not going to change what I would do. So I wouldn't necessarily do a testosterone on that patient. This patient was treated with weekly D2 and talked about with calcium, falls prevention, weight-bearing exercises. The patient was given the option of an anti-resorptive, a medication which slows the bone loss down, or an anabolic agent which helps to rebuild the bone. There's that reference I was talking with all of you about, the Clinician's Guide to Treatment and Management of Osteoporosis. And the patient wants to follow up with his PCP only. Well, that kind of brings us back to why do we need this program in orthopedics? Well, I want to point out to you, every patient that we see, if they say to us, well, I already have a primary care provider that's treating my osteoporosis, my orthopedic surgeon or my orthopedic PA and nurse practitioner that's seeing the patient for their post-fracture simply says to them, we totally understand and we want to work with your primary care provider, but now you've had a fracture and we want to make sure that we've given you all the treatment options that you can have to help strengthen your bones and reduce your risk of another fracture. So you do need to go ahead and see our bone health specialist, our fracture liaison specialist, and they will coordinate with your primary care provider. And certainly you can follow up with your PCP, but we just need to make sure that you see our provider as well, especially during the 90-day period of time because they're going to be coming back in anyway. So try to get them to your FLS, and then you can coordinate with the primary care provider as well. The other thing that I want to mention, here is that you may have different protocols that you're setting up for yourself, but what we just ran through was the second I that I mentioned. So we've got 3 I's. We've got identify, investigate, and initiate. And so we just went through the investigation part, and that would be for clinicians that are actually on the call and kind of want to know, well, what does a normal patient look like, and how would you handle this patient? Let me check and make sure there's no questions in the queue real quick. No questions? No other questions?
Okay,
all right,
great.
very good. So Debbie, would you like to continue? What would you like to do at this point? I've kind of covered everything that I need to cover for the FLS standpoint. Maybe just give another few minutes to see if anybody has any additional questions. I know we still have a little bit of time, but I want to, if people have gotten what they needed from the call, I'm happy to go on with another case or whatever. What would you like to do?
No, that sounds good. We'll wait one moment to see if there's any other questions. In the meantime, I'll just remind everyone to click on the question button, and then you can enter in the questions that you have, that the webinar will be available on YouTube next week, as well as on the Fracture Prevention Central site, and we will also be sending out the slides. And I see that there is one question, Ann, so I guess you have time for one more question, and then we can wrap it up.
Yeah, it says here, oh great, here we go. We got a couple more questions. I had a patient with a BMD in osteoporotic range, but frac showing 10-year risk less than needed for treatment. Well, first of all, if a patient has osteoporosis, then your frac score should not be done. It's just the way the tool was set up was simply to identify the risk, but a patient with osteoporosis already is at high risk. So you don't really need a frac to show that they're at high risk. They need treatment. Now, if you have a patient that has osteopenia and they've never been on treatment for their osteopenia, so they've never been on an anti-resorptive or anabolic agent, and they're osteopenic, then a frac score is appropriate. If you look at the fracs and the frac shows that their risk of a major osteoporotic fracture anywhere else in their body except their hip is greater than 20%, that would be high risk. If they have a risk of a hip fracture of greater than 3%, that's high risk if they're in osteoporotic range. Now, I will pose to you, the person who's asking me this question, if you had a patient with a BMD and osteoporotic range, but the frac score showed low, then the fracs is not legitimate because the patient has osteoporosis. The second thing that I would tell you is the patient needs treatment for sure, and so you as the clinician are not robotic. You're the smart one, not the frac score. You don't need the frac score anyway. You're the smart provider who saw the osteoporosis and who is going to be able to put that patient on treatment. The other thing that I would say is I would need a little more history about that patient because there's some reason they have osteoporosis. Maybe they have some medical conditions. Maybe they're diabetic. I want everybody on the phone call to keep in mind now that it's not just insulin-dependent diabetics that are at high risk for osteoporosis or compromised bone quality, but it's all diabetics, because this research that's just recently come out about collagen and the protein and the breakdown of what happens in the bone related to a chemical called pentosodine in patients that are diabetics. Any of your diabetic patients, if they're over the age of 50, really should get a bone density test done. But if this patient has osteoporosis, they need treatment, and I would certainly recommend that you look at their medical history and then get them on some kind of treatment. Forget about their frac score. This is where we all go back to that. We all learn this as clinicians. We treat the patient, not the lab. This is where you're gonna look at that bone density and say, no, that bone density shows osteoporosis. I'm not going to worry about that. The frac doesn't mean anything to me. This patient needs treatment because they're at high risk. And you also want to make sure you have a good quality bone density. Whoever did that bone density shouldn't have done there should not have been a frac associated with that if it was osteoporosis. In your interpretation of that bone density at the bottom, it should have simply said frac score not applicable in presence of osteoporosis. That's what it should have said. So not to confuse the provider who's looking at it. But that's a great question. I would like to continue this because it's informative. Okay. Yeah, so she said, in this case, I tended to ignore. Perfect. You did the right thing. Way to go. You ignored the fracs because it shouldn't have been done. And then I've got a question about logistics. What are your follow-up schedules, and when do you refer back to primary? Do you have process or maps or algorithms capturing the patients, treating them? And then somebody was asking about insurance barriers. Okay, so as far as my follow-up visits, normally I'm going to see the patient. I try to see the patient within two to 4 weeks post-fracture. We try to get them in for their initial workup with me. The reason for that is, number one, it's a teachable moment because they just had a fracture. They're in rehab. They're going to be more likely to be thinking, I don't want to do this again, and so they're going to be more. They're going to be thinking more aggressively about taking care of their bone health. So we try to get them in fairly soon. At the initial visit, I see if they have any questions or lists or agendas or ideas or expectations. I do what's called icing the patient. So I ask them about their ideas, their concerns, their expectation of the visit, and kind of listen to how they had the injury. And then I do some educational with them. I'll do the blood work, and I'll order the bone density test. And then I give them the packet of information to take home and review about treatment options. I usually schedule them 2 to 3 weeks after that so they have time to digest the information. And then at their 2 to 3 week follow-up, if they haven't started therapy, haven't started any treatment at the very first visit, if I wasn't convincing enough, I'll have them come back, and then I'll start them on treatment at the 2 to 3 week follow-up visit. If I start them on an anti-resorptive medication, I'm probably going to see them in 3 to 6 months to making sure they're staying compliant, because the current research shows that a lot of patients started on osteoporotic medicines actually stop their treatment, just stop it randomly after 6 months. So I actually want to check on their compliance, and I equate it to treating a patient like I would a diabetic that I'm starting a new medicine on, or a high blood pressure medicine. I want to make sure they're being compliant. And so I bring them in, make sure they're tolerating it, no side effects, they're still taking it, and those kind of things. So it's usually 3 to 6 months initially, and then if they're doing really well, if I have them on an anti-resorptive, I won't see them for a year after, for 9 months after that. If I have them on an anabolic agent, I won't see them until the 9-month mark. So it's usually first visit, follow-up 2 to 3 weeks, follow-up at 3 to 6 months, and then a follow-up at the year mark of treatment. So that would be my normal template for seeing a patient. Do I refer back to primary care? If a patient wants to go back to their primary care provider, I am happy to do that. A lot of times when I give the patient the option, I'm going to tell you hands down, a lot of times they will look at me and say, nobody's ever talked to me about my bones. I don't want to fracture again. You guys have fixed my broken bone. I just would rather stay with you for my bone health. So you may get some of that, but if they want to go back to primary care, every primary care provider gets a copy of my initial note anyway, so I keep them in the loop for care coordination, but I leave it up to the patient. If they want to go back to primary care, I will refer them back after I know that they're being compliant with treatment, so it's usually going to be at that 3 to 6 month mark before I'll refer them back to primary care. Do you have a process maps or algorithm for capturing patients and treating them that you would share? Do me a favor, whoever this is, I think whoever's asking me that question, what I'd like for you to do is I would like for you to reach out to Debbie and see about getting that one-on-one consult with me, and I will be happy to talk to you about how we do it, because that's a great question. I'm so glad you asked that, because that's the #1 challenge that most people have with keeping their program sustainable, and it's capture. So I would love to answer that for you, you know, on a one-on-one consult to talk about my process. That's a great question. I just don't think we have enough time to go into it. And then the last question, I think I've got a couple of more minutes. Let me answer this last little question here. There's a couple more. I'm sorry I might not get to everybody. There's one patient that's one person that's asked me, can I address some common issue insurance barriers? Love those, gotta love those, that you run into with the average patient, such as needing to use a bisphosphonate before an anabolic agent, and how I deal with it. Okay, great question. Real quick, what I do is, first of all, every insurance company is always thinking primary prevention. They're always going to want us to go to an anti-resorptive first, because they're cheaper and they're generic and they've got great medical science behind them. They're great medications. So there's always going to be that little hiccup. But what I do from an orthopedic standpoint is when a patient has had a fragility fracture, they're automatically at high risk for another fracture. So that's the first thing I put. Patient has osteoporosis at high risk for a future fracture. That's my assessment. Then I look at their medical diagnosis and I put every comorbidity, every medical condition that would contribute to compromised bone strength. They're diabetic, they have been on chronic current opioid use, chronic oral steroid use, long-term use of PPIs, positive family history of osteoporosis, history of prior fragility fracture, whatever. That goes all in my note. And so if I get a denial on a patient, if I want to put them on an anabolic agent and they want me to try something else first, I have an appeals letter that I send in. And we basically tailor the appeals letter indicating every reason the patient needs to be on that medication that I've selected. Okay? So far, up until this week, it's funny you should ask, but so far up until this week, every time we sent the appeals letter in with the justification, the patient gets approved for the medication. I'm happy to share our appeals letter with anybody who wants it. You can send a note to me, actually. Send it to my email. It's, don't laugh, it's aflake, A-F-L-A-K-E, at wakehealth.edu. So it's aflake, yes, you heard it correctly, at wakehealth.edu. Send me your request. We'll be glad to send you a copy of the appeals letter that we send, and basically you can tailor it and put in the medical information that you want about your patient, and that may help you. Just this week, I actually have to request a peer-to-peer. This is the first time in the last 4 years that I've had to do an appeal or a peer-to-peer because they've denied 2 appeals, and it has to do with a certain insurance company. I really wish they'd get on board, because I think if they would understand that it's going to cost them more to fix a hip fracture than it would to cover the medication, they'd be doing a better job. But anyway, nonetheless, but yeah, I do run into those, but I use that appeals letter and I try to justify every legitimate reason for the patient needing that treatment that I've selected for them. Somebody asked about the slides again, and yes, the slides will be available. So I'm going to turn it back over to Debbie. Oh, guys, you guys have been awesome. Thank you so much for hanging in there with me. Thanks for eating your lunch with me today. Appreciate your time. I know it's a sacrifice, and I hope you found it informative and also fairly informal, and hopefully I was able to get to your questions. Happy to follow up with any of you. I hope you have a great day. Turning it back over to you, Debbie.
Great. Thank you, Anne, and thank you everyone for joining us for today's webinar. As I mentioned earlier, we will be sending a follow-up email that will include the slides that Anne used, as well as a link to the YouTube video of today's webinar. We hope you will join us for our next webinar on June 20th. Thanks so much and have a great afternoon.
Are you staying on, Debbie?